This segment is on heart failure. Heart failure used to be called congestive heart failure, and in fact that's may be what you were taught in nursing school. But the correct terminology is heart failure. So if you see a question and the patient has heart failure, you will think in your mind congestive heart failure, because that's what is really being talked about. Congestive heart failure simply means that the heart isn't effective as a pump anymore. Now, I want you to think about a patient who's had high blood pressure for the last 15 or 20 years. Now, which chamber of their heart has to work harder because of their high blood pressure? That's right, it's the left ventricle. And the left ventricle will enlarge and eventually become less effective as a pump. And when it can no longer effectively pump blood out through the aorta, the blood then begins to back up into the left atrium, and that's fed by the pulmonary veins. So it backs up into the lungs. So left failure gives you lung symptoms. So the patient will get crackles and rales, and the lungs will begin to fill up with fluids. They'll get dyspnea. Now, when the patient has lung congestion, so if they had left-sided failure with lung congestion, which chamber of the heart would have to work harder to pump the blood through the lungs? That's right, it's the right ventricle, and then this can cause right ventricular hypertrophy, so it enlarges, becomes less effective as a pump, and it backs up then from the right ventricle to the right atrium. And remember, the right atrium is fed by the vena cava. So the right failure gives you venous symptoms. The patient would get distended neck veins, an enlarged liver. The liver is right about where this word ventricular is here. And then they would have pitting peripheral edema. So right failure gives you venous symptoms. Left failure gives you lung symptoms. A 68-year-old is admitted with left-sided heart failure. What assessment findings would the nurse expect in the client? 1, distended neck veins, hepatomegaly. 2, dyspnea and ankle edema. 3, hypotension and tachycardia. Or 4, PVCs and tachycardia. And the best answer here is number 2. Now, you easily picked out the dyspnea, I'm sure, from left-sided failure. In left-sided failure, you might have ankle edema, but you would not have pitting peripheral edema. Now, look at those answers and see which one of those answers would suggest right-sided failure. And that, of course, would be answer choice number 1. Now, if a patient has heart failure, we need to think about what might be done to treat heart failure. And there's a whole number of drugs that are used. The first I want us to look at are ACE inhibitors, the angiotensin converting enzyme inhibitors. These block the conversion of angiotensin 1 to angiotensin 2. These are prils, enalapril, captopril. So pril is their family name. Another drug that is frequently used to treat heart failure is digoxin, and we'll talk about that in more detail in a moment. Another drug, beta blockers, and their family name is Olol. We'll look at those in more detail in a moment. Diuretics are frequently used along with the other drugs, drugs like Lasix and sometimes hydrochlorothiazide. And we also see the aldosterone antagonists, which are sometimes called your potassium-sparing diuretics like spironolactone. So let's go back and take these and look at each of these in more detail. The ACE inhibitors, enalapril, which is Vasotec, or captopril, which is Capitan. As we mentioned, they block the conversion of angiotensin 1 to angiotensin 2, and this causes a vasodilation. An interesting, nasty little side effect of the ACE inhibitors is a cough. And this is a little dry cough, not a productive cough particularly, but just an annoying little cough that some patients get. Like any drug of these heart kind of drugs, orthostatic hypotension is a potential side effect. This ACE inhibitors are best taken about an hour before meals. And note that drugs like antacids and NSAIDs, that would be your ibuprofen type drugs, may decrease the effectiveness of the ACE inhibitors. Another major drug used to treat heart failure is digoxin. Digoxin is an absolute must-know for NCLEX. It slows and strengthens the heart, and because of that, it can increase the blood supply to the vital organs. It works on both the SA nodes and on the SA node and the AV node. Some other interesting things about digoxin. Sometimes digoxin is started with a loading dose. That means that the patient may be given 1 or 2 doses, that's double the normal therapeutic dose. Now, digoxin stays in the body about a week, so it's a very long-acting drug, and that's one of the problems with it. Since it stays in the body a week, there's a great potential for the development of toxicity. So they may, even if you picked up toxicity, you would still have drug in the body for the next week. So let's say it was Monday and you picked up drug toxicity. There would be drug in the body that the patient had taken Sunday, Saturday, Friday, Thursday, Wednesday, Tuesday, and even last Monday. So we really have to pick up signs of toxicity in patients who are taking digoxin. If the job of the drug is to slow and strengthen the heartbeat, then one of the toxicities would be bradycardia, and indeed that's the case. You would withhold digoxin in an adult if the pulse was below 60. In a child, in an infant, you'd be looking at 100, and a toddler 90. Now I'd like you to make a promise to me. I'd like you to promise me that if you see a question with a patient on digoxin and something about a heart rate, you will double check the age of the patient. Remember, for adults, you would withhold digoxin if the pulse is below 60, so 59 or less. In infants, we're looking at 100 as the cutoff point. Toddlers, it will probably be 90. Digoxin sometimes causes other dysrhythmias. So if there are bigeminies or unexplained other dysrhythmias, a possibility is digoxin toxicity. Digoxin can cause anorexia, nausea, and vomiting. So that's something to be on the lookout for. Sometimes patients who are in dig toxicity will say to you, how come everybody's wearing green but they aren't? How come the whole world looks yellow but it doesn't? Not to you anyway. In that case, it would be time to get a serum digoxin level and see if the patient was in digoxin toxicity. It's important to monitor serum potassium levels, not because digoxin in and of itself will affect the serum potassium, because it doesn't, but it's frequently given along with Lasix, which is a potassium depleter. And when the serum potassium levels are low, then you can get dig toxicity more quickly. So when you give a patient digoxin and Lasix, you're really setting them up for digoxin toxicity. I think you should know the serum dig levels. The therapeutic levels are usually something in the 0.8 to 2.0 nanogram per milliliter area. Toxicity occurs at levels greater than 2.5 nanograms per milliliter. The general rule is you would withhold digoxin and notify the physician if the serum digoxin was greater than 2.0. There is an antidote for digoxin, and that's a drug called Digibine. Sometimes you'll see that referred to as FAB immune digoxin, and that can be given in severe cases of digoxin toxicity. A question for us. The nurse is preparing to administer the daily dose of digoxin to an adult. Which finding would cause the nurse to withhold the medication? 1. The client's pulse is 60. 2. The client complains of nausea. 3. The client's output for the last 8 hours is 1,200 milliliters. Or 4. The client's serum potassium is 4.0 milliequivalents per liter. And the correct answer is number 2. The client complains of nausea. Now this one's a little tricky. Notice that the pulse is 60. 60 you can give it to an adult, 59 you would not. Answer number 3 says the urine output is 1,200 for the last 8 hours. That's a little high, but not unusual for someone on digoxin, because as the heart beats more effectively, you get rid of the extra fluid. And notice the serum potassium is 4, so what's the normal serum potassium? That's right, 3.5 to 5.5, so that serum potassium is perfectly normal, within normal limits. I have another question for us. Furosemide and digoxin have been prescribed for a person who is admitted in heart failure. What should the nurse do to determine if the drugs are effective? 1. Auscultate the chest. 2. Assess skin turgor. 3. Check the serum potassium level. Or 4. Observe what the client eats. So the correct answer here is answer number 1. Now let's look at the question a bit here and make sure we're answering the question that was asked. So the patient's getting furosemide, which is Lasix, and digoxin, and they have heart failure. Now this is an evaluation question. What do you do to determine if the drugs are effective? So what would be the symptoms of someone who had heart failure? All right, they would have crackles. They'd have fluid in the lungs. So if digoxin and Lasix were working properly, what changes would you see? What effect would that have? Hopefully there'd be fewer crackles. And so how would you determine that? You would auscultate the chest. And that's why that's the best answer. All right, now let's move on and talk about a couple of those other drugs. Let's talk about beta blockers. Beta blockers, we said, were olols. So their family name is olol. They are antihypertensive in effect. They cause a peripheral vasodilation, which means that a major side effect is orthostatic hypotension. They are best given with food because when you block the adrenergic system, that means you will have more cholinergic or those GI secretions being produced. And obviously you would monitor pulse. If the pulse is below 60 in an adult, you would probably withhold the medication and check with the physician. Let's take a look at the diuretics. There are several types of diuretics I think we should look at. The thiazides, like hydrochlorothiazide, and loop, like furosemide, which is Lasix. These diuretics are what we call potassium depleting diuretics, because one of their major side effects is a lowered serum potassium level. Now notice that these drugs can cause orthostatic hypotension. It's often particularly severe with hydrochlorothiazide. There can be a decrease in serum sodium level, but the biggie problem is usually the serum potassium. Now, I'm pretty sure that NCLEX has on occasion asked where Lasix or furosemide works or how it works. It works by inhibiting reabsorption in the loop of Henle. So hence the name loop diuretic, because it works in the loop of Henle. I also want us to look at the potassium-sparing diuretic, spironolactone, sometimes also called aldactone, that's the trade name. What this does is block the action of aldosterone. Now, if you remember, aldosterone is put out by the adrenal cortex, and it says to the kidney, hold on to sodium and water and get rid of potassium. So if this drug blocks that, it gets rid of sodium and water and holds on to potassium. So the side effect of the potassium-sparing diuretic like spironolactone would be hyperkalemia. Now let's talk a little bit about foods that contain potassium. If the patient is on Lasix or hydrochlorothiazide, they're likely to be needing a high potassium diet. And if I asked you about it, you would probably all tell me oranges and bananas. But if you look at the list, those aren't the highest. The highest one on this list happens to be watermelon. Watermelon contains large amounts of potassium. Other things high in potassium, prunes, baked potato, lima beans, soybeans, all of those things are high in potassium. Even milk has potassium. What you don't see on that list are breads and cereals, and breads and cereals are not particularly high in potassium. On the exam, they're probably not going to give you so much bananas and oranges. They're going to give you melons. They're going to give you prunes, apricots as food sources that are high in potassium. Remember, if they're on Lasix, which is furosemide, or if they're on hydrochlorothiazide, we would need to make sure they had lots of potassium in their diet. If, however, they were taking, they had renal failure, so they were in acute renal failure or chronic renal failure, they would probably need to be on a low potassium diet, which means they would have to avoid those foods that are high in potassium. That would be a very difficult diet to adhere to. Another question for us. An adult is admitted in heart failure. His condition deteriorates. His respirations are rapid, noisy, and moist. He is becoming cyanotic and restless. Morphine 10 milligrams IV is ordered stat. The nurse understands that morphine is ordered to 1. Reduce pain. 2. Induce vasodilation. 3. Slow the heart rate. Or 4. Reduce coughing. Now this is a bit of a tough question because morphine can actually do all 4 of those things. So, now look at the data in the question. He's admitted in heart failure and he gets worse. That means that this question is referring to pulmonary edema. That's what happens when heart failure gets worse. And the reason that morphine is ordered for that pulmonary edema patient is answer number 2, to induce vasodilation. And that causes peripheral vasodilation, causes a reduction in venous return. And so that means that it reduces the cardiac workload for that patient. All right, I want us to move on and talk about a couple other conditions. I want us to talk a little bit about endocarditis and pericarditis. Endocarditis is a bacterial infection usually, so it would be treated with antibiotics. I can think of a couple of types of endocarditis. One is rheumatic fever. And in rheumatic fever, then the question might be what would be in the patient's history, and that means that you would see a pharyngitis or a strep throat in the patient's history. If you saw a question that said, which factor in the patient's history puts them at increased risk for endocarditis? It could be the pharyngitis or strep throat. Another possible answer could be IV drug abuse. And you can get then the bacteria into the bloodstream that can get and affect the inner lining of the heart, which is what endocarditis is. Now when that inner lining of the heart has been inflamed, this puts the patient at increased risk for clots and also congestive heart failure. Pericarditis is inflammation of the outer lining of the heart. It can be bacterial, viral, fungal. Antibiotics would be appropriate for bacterial, but not so much so for the viral. Steroids, salicylates might be used. We could also use salicylates for endocarditis as well because of the risk of clots. Pericarditis, there's usually pain on inspiration. If they ask that question about factors in the client's history that put them at risk for pericarditis, the answer I would be looking for would be something like IV drug abuse. Now, it's possible that pericarditis could follow a viral infection, a cold, but very often it follows IV drug abuse. One more condition for us to look at now is cardiac tamponade. This is a collection of blood in the pericardium. The pericardium, of course, being that outer sac around the heart. Usually there's just a slight amount of fluid in there, just enough really to keep the membranes from rubbing together. In cardiac tamponade, you get a big collection of blood in that pericardial space. Then when you listen for the heart sounds, they sound like they're 100 miles away. They're very distant, muffled heart sounds. The physician will do a pericardiocentesis, remove the fluid from the pericardial sac. Now, I thought I'd just show you a picture. This shows a normal heart, and this shows fluid in the pericardial sac. And that's why it's so hard to hear those heart sounds. Here's another view of that with, this is another view of that cardiac tamponade. You can really see the pericardium filled with fluid. This patient obviously required a surgical intervention for that.